Good morning, everyone. Thank you so much for being here. I'm Alice. For those of you who haven't met, I'm one of the chief residents this year. Excited to kickstart the Chief Talk series. Thanks all for the opportunity to talk about a topic that I've become increasingly interested in, patient-reported outcome measures, and what I think is very important in providing quality of life-centered care in a surgical specialty. So I'll start with some background on what patient-reported outcomes are, why we should care about them, provide some evidence on existing PROMS in otolaryngology and evidence for their validation and kind of clinical application, go into some barriers to their development and utilization, and then end with some next steps on improving their implementation and future directions. But if you will allow me to start with a brief personal story to maybe provide some insight into my interest in this topic. Some of you already know my journey to otolaryngology actually started quite early. Some of my earliest childhood memories and most of my memories about my father were of his battles with the consequences of nasopharyngeal carcinoma. He suffered from a lot of different side effects, ranging from hearing loss due to chemotoxicity and chronic otitis media to dysarthria and shoulder and neck neuropathy that led to him having speech that was unintelligible to most people aside from his family. I remember us driving back and forth between Madison and Milwaukee for him to receive hyperbaric oxygen treatment in a somewhat desperate effort to improve his xerostomia, trismus, and severe dysphagia. Despite that, he ultimately required a long-term G-tube or gastric tube placed. And I remember feeling very guiltily embarrassed to have to help him with feeds when we were eating out or on vacation. And despite having a G-tube, he still contracted aspiration pneumonia at least once a year, if not more frequently. So, by the measure of many of his doctors and from an oncologic standpoint, he was considered a treatment success as he remained cancer-free for the majority of my life. But as I hope you can get a sense of, and I know many of you have experienced with your own patients, treatment effects can leave patients with greater suffering than maybe even their disease did and become a greater component of the care that we provide for them over time. I think the patient experience really comes with our territory. There's just such a substantial functional component to otolaryngologic conditions. The ability to sleep well, to breathe, speak, taste, look the way that we want to is so integral to the way that we interact with the world and can be very difficult to characterize. We know from experience and from studies that many of our objective measures of disease severity don't correlate with symptoms or functional status. And so, as a result, treatment success can mean something very different to patients than it does to clinicians. Clinician-reported outcome measures often center on rates of oncologic or disease control in the form of survival rates, incidence of surgical complications, of treatment toxicity, adverse events like readmissions. Quality of life assessment is often based on post-treatment exam or imaging findings, maybe the rate of additional interventions like trach or peg placement. There is a need to do a lot better in assessing functional status, symptom burden, and patient satisfaction. This is necessary because studies show that we as clinicians consistently underreport treatment effects and symptom burden compared to patients. Seeing this trend really highlights the gap that could potentially be filled by patient-reported outcome measures, or PROMS. These are self-rated and self-reported measures of health-related quality of life at a single point in time or a defined time period. They were originally developed as a research tool and to identify areas for quality improvement, but have become increasingly integrated into patient care in an effort to really refine surgical outcomes as part of, on a larger national scale, the shift towards value-based reform and as part of the general push for patient engagement in health and medical decision-making. So to delve further into this, on a patient level, I think there's an obvious potential for PROMS to optimize quality of life and identify patients who would benefit from further management, further intervention. On a day-to-day practice level, I also think that these instruments can greatly improve patient-provider communication. We all know all too well the patient who comes in with a fairly nebulous or vague complaint or a constellation of symptoms. A well-constructed survey can really help steer the conversation towards what truly matters to the patient and increase both patient and provider satisfaction with the visit. This has actually been borne out in studies that have shown that providers who discuss PROMS with their patients consistently score better on physician communication skills and shared decision making. Taking it up a notch, could the use of PROMS in clinical practice actually impart a survival benefit? This landmark study by Bosch et al. Randomized over 700 lung cancer patients to either a usual standard of care group or a patient-reported outcome or PRO group. And those in the latter were instructed to fill out a web-based electronic questionnaire at and between visits. And any report of a high severity symptom or a worsening symptom would trigger a clinical nurse to follow up on this report. And they found that at 2 years, those in the PRO group had a significantly higher overall survival than those in the standard of care group. And this finding has been mirrored in larger studies, including this meta-analysis that investigated PROM use across all different types of cancer, and in their pooled analysis similarly found that the addition of a PROM was associated with a reduction in overall mortality. On the research front, PROMs really open up a whole other area of study in facilitating and expanding upon treatment comparisons and aiding in the assessment of quality of life endpoints in clinical studies and potentially even identifying novel endpoints for study. Taking it back to aspiration pneumonia, this continues to be an underreported long-term sequelae of chemoradiation for head and neck cancer, and it's one that's associated with high mortality. Could symptoms that are reported on post-treatment or even pre-treatment PROMs be used to identify those at risk for developing aspiration pneumonia? In a similar vein, recognizing patterns in the incidence of patient-reported outcomes can also aid in highlighting novel endpoints for study or important considerations in perioperative care. From my personal family's experience, but also just being part of the care for many NPC patients during residency, I noticed that the majority were coming in with a primary or notable complaint of xerostomia and neck fibrosis and stiffness, and also recognizing that these patients diagnosed early were living long lives, surviving their cancer, and likely undergoing procedures at a later time, either related to a totally different condition or as a part of their long-term sequelae like osteoradionecrosis. And suspected that there might be a significant impact on airway outcomes as a result of treatment effects to their anatomy and function. And indeed, in our retrospective review, we found a 7-fold increase in the rate of difficult intubation when patients presented with either reported or clinician-measured trismus and neck fibrosis. And so that should really have significant implications for their perioperative care. And the final consideration being payers. So currently, our healthcare system and funding on a federal level is in tremendous flux, but over the past decade, there's been a shift from volume-based fee-for-service reimbursement towards value-based payment models, being able to prove that the care you're providing is quality. The Merit-Based Incentive Program, or MIPS, was established in 2015 and has been effective since 2017. It scores Medicare clinicians based on 4 different categories of performance. Quality of care is one of them and comprises 30% of that score. The Center for Medicare and Medicaid Services also will require data to be submitted on shared decision-making and patient outcomes, and that you are able to demonstrate the quality of care that you provide. The National Cancer Institute has also called for PROMs to be a routine part of patient-reported measures in all future clinical head and neck trials, kind of further underscoring their importance in the management of these patients. PROMs are actually already used as a benchmark for surgery in other countries. For example, in the UK, the National Health Service actually sets thresholds based on PROMs. The sinonasal outcome test, for example, the SNOT 22, they have set a threshold that if a patient is undergoing consideration for sinus surgery, if their score is below that threshold, indicating a relatively low symptom burden, their surgery wouldn't be reimbursed. Here in the U.S., if they meet diagnostic criteria, which is usually radiographically based or based on a constellation of symptoms set by clinical practice guidelines, or have documented kind of failed surgical therapy, that's sufficient justification to for their surgical candidacy, whether or not those factors have been deemed to be predictive of disease improvement and treatment success. So with all of that in mind, I'd like to go through some of the most commonly employed patient-reported outcome measures in our specialty, highlight some strengths and weaknesses, and go through the evidence behind their clinical applications. Patients with head and neck cancer are really an ideal group to benefit from the use of PROS in clinical care because of the high burden of acute and chronic treatment effects with potentially actionable interventions. On the flip side, as a whole, there can be a particularly tricky group for which to really develop tailored outcomes assessments because their post-treatment dysfunction can be so multifaceted and a complex interplay between their disease subsite or their treatment modality. Nonetheless, there are many existing PROMs. This systematic review goes through 12 of the commonly used ones, and you can see the incredible kind of variety of domain that they cover, from facial appearance to speech and swallow function to psychosocial well-being. The majority assess kind of general head and neck quality of life, and others are more domain specific. One of the oldest and most well-known is the University of Washington Quality of Life Questionnaire. It was created in 1993 and is available for free online. It consists of 12 different domains, the average of which makes up the composite or total score that can range from 0 being the worst quality of life to 100 being the best. This is what the questionnaire looks like. I just want to point out the specification of a time period in order to really increase the relevance and kind of sensitivity of the tool. Its strength is that, despite covering a fairly broad range of domains from pain to taste to cancer anxiety, it's still relatively concise, explicit, and manageable. I also like that it asks at the end what 3 domains the patient's most concerned about to really further hone in on their symptom burden. This tool has been used in many studies. We see it used as a primary endpoint in this large prospective study, including head and neck cancer patients and trending their yearly quality of life scores over time, revealing a significant influence of TNM stage and cancer subsite on both short and long-term quality of life. The authors also summarize kind of lessons learned from conducting a large quality of life-based study. And I wanted to highlight 2 things that they brought up. One being they found that the composite or total scores were in many cases not sufficiently sensitive enough to really detect meaningful changes in patients' experiences, and instead recommend really honing in on domain or item-specific scores to understand their experience and their symptom burden and better inform clinical counseling. And the second, which I included in quotations there because I liked the way that they worded it, but in essence says that finding statistically significant results or differences in quality of life can be really challenging, even in multi-institutional studies, simply because there's such a high variability in patient experience and because of the human tendency to really adapt to disability over time. The corollary to that, and my main takeaway, is that when a quality of life difference is demonstrated, it's probably very real and significant. So when considering these instruments, a common term you'll see is psychometric validation. And the term psychometric just really refers to its measurement properties and the scientific evaluation of its reliability, its consistency, its applicability. And one of the most important psychometric properties is content validity. At its heart, does this tool evaluate or measure what it's actually trying to measure? One way to establish that is by correlating with objective measures or clinical measures that we are already familiar with. And so we see that in this study that's looking at the impact of dysphagia on quality of life after treatment for head and neck cancer. And you can see that patients who have a low-grade swallowing dysfunction based on modified barium swallow studies also have high scores in the swallowing domain on the EW Quality of Life questionnaire. So that's an example of establishing the content validity of an instrument. And that's really imperative in order to generate relevant data that can contribute meaningfully to patient-centered care. 20 years later, the FACE-Q head and neck module came out of Memorial Sloan Kettering Cancer Center. One of its strengths is that it's really one of the first to delve into detail into the impact of changes in facial appearance in this patient population, which you can imagine is particularly relevant for us given the intense ablative and reconstructive surgeries that patients are undergoing in this context. Again, note the specification of a time interval in order to really track progress over time. It's ideal for clinical practice and for research purposes. Given the recency of its development, there are fewer studies that employ the FACE-Q head and neck module, but it was recently extensively validated and is becoming one of the more promising alternatives to older instruments. So moving away from head and neck cancer and towards other subspecialties that have less of a focus on cancer, the majority of conditions are not life-threatening and instead impact quality of life or impart a functional disability. We do see more robust psychometric validation of instruments here and more widespread utilization in practice. This large narrative review looked at the 100 top cited PROMS in otolaryngology, and you can see the most prolific areas are otology, neurotology, rhinology, and laryngology. A famous one that we all know is the SNOT, or the sinonasal outcome test. It comprises of 22 items across 4 subdomains, including sleep, nasal symptoms, otologic symptoms and facial pain, and emotional burden. Beyond it being very well validated, one of its strengths is that it has an established minimal clinically important difference, or MCID, of 9 points for a patient with chronic rhinosinusitis. This means that if there is a change in score of 9 points or greater, it is likely reflecting a significant improvement or worsening in their symptoms that the patient will notice. The SNOT-22 was utilized in one of the largest outcome studies to date in chronic rhinosinusitis that included over 3,000 patients and prospectively collected their SNOT scores both before and after surgery for CRS, and showed a clinically significant or greater than 9-point drop by 3 months after surgery that was sustained over 5 years for both polyp and non-polyp patients. So definitely incredible evidence supporting the use and efficacy of surgery for treatment of CRS. The rhinitis quality of life questionnaire we don't see as much, but is actually a very well validated instrument, the best one for allergic rhinitis. I think that both this instrument and the SNOT-22 are particularly useful for even just defining patient symptoms and isolating their dysfunction. For example, the term congestion means something very different to patients than it does to providers. I would argue there's sometimes even inter-provider variability in the definition, and so I think that seeing how they answer specific questions really pinpoints what they're trying to describe, and that again loops back to the importance of content validity of these surveys. A big part of that is putting things into patients' words. Into the realm of facial plastic surgery, another PROM with very sound psychometric validation was actually developed here by Dr. Most and company. The Standardized Cosmesis and Health Nasal Outcomes Survey, or SNAS, evaluates the functional and cosmetic outcomes of rhinoplasty. It is robustly validated across multiple languages. To use it to demonstrate some of the psychometric properties that we're considering, it has high internal consistency. That means its individual items or domains are all reflecting the same underlying construct. It has strong reproducibility, which means you give the patient the survey, the same patient, the same survey, you'll get the same results multiple times, and has been demonstrated to reliably distinguish patients with different levels of impairment severity. Not only does it have an MCID, it actually has a differential score for the obstructive domains and the cosmetic domains. So that can be particularly useful in counseling patients on what to expect. I just want to touch briefly on the FACE-Q aesthetic scale. We do not see this used as much in otolaryngology. I think it's probably more frequently used in plastic surgery. It's designed to assess the impact of cosmetic procedures on quality of life. I bring it up because I think it shows a potential drawback to PROMS being how time-consuming they can be. This screen grab is just the section on satisfaction with lips, but it actually comprises 40 different independent scales and checklists, and you can imagine how cumbersome that can be for both patients and providers to review. But we'll touch on that more when we discuss barriers to PROM utilization. Despite there being relatively few validated PROMs in sleep medicine, I would argue that they are essential for evaluating the impact of sleep surgery interventions in particular on patients' quality of life and symptom relief. You know, patients aren't coming to us complaining of an AHI of 20. They're saying they're falling asleep in situations that they don't think they're supposed to be. So again, PROMs are really so much more relevant to the patient than a lot of the objective measures of disease that we're utilizing in their workup and counseling. 86% of studies in a systematic review looking at PROMs used for obstructive sleep apnea employed the ESS, or the Epworth Sleepiness Scale. It's one of the most prominent most widely used PROMs. It also has an MCID. And to just provide some context with the clinical application, it has been used to really establish the efficacy of many of our surgical interventions, including UPPP. Neurotology PROMs actually comprise the greatest proportion of the top cited PROMs in otolaryngology. When considering symptoms that are difficult to characterize, I think dizziness has to be on the top of that list. The dizziness handicap inventory, I actually didn't realize until recently that it's incorporated into the vestibular workup here by our audiologists. But it's actually one of the oldest and most widely used PROMs in otolaryngology. It is scenario-based and assesses how often respondents have dizziness-related distress in those scenarios, and has been widely used in Meniere's disease and vestibular migraine. There is a little more controversy over the robustness of its scientific validation. I think part of that is it was just developed so long ago, it hasn't been re-examined, and so that is one of the potential drawbacks. I was surprised to learn that until recently there were no rigorously validated PROMs to assess quality of life in the adult CI population or cochlear implant population, despite it being widely acknowledged that speech recognition is inadequate in many cases for assessing CI user benefits. In 2020, MUSC developed the Cochlear Implant Quality of Life Item Bank. They performed extensive testing and actually generated models that allow for the use of pre- and post-implant scores to be used in combination with normative data or data from the general population to provide a framework for CI counseling. So using these models, you can help predict successful implant usage, set realistic expectations, track changes in satisfaction with the implant, and even develop individualized rehab strategies. We, or at least as residents, know all too well the many forms that we're always sifting through rapidly in laryngology clinic. There are many PROMs in laryngology. I wanted to focus on the Voice Handicap Index. It was originally a 30-item questionnaire, but I think the abbreviated version may be more frequently used. It consists of 10 items. Both have been validated. What stood out to me about the literature here is that there are studies that demonstrate its utility not only in characterizing vocal dysfunction, but also studies that suggest it to be used as kind of a screening tool and for preliminary diagnosis. So they show that for patients with benign vocal fold lesions, they have significantly higher VHI scores, and actually propose a cutoff score that, in their study, we were able to demonstrate pretty high sensitivity and specificity in detecting a vocal fold pathology. You can imagine applying such a screening mechanism maybe to vocal fold paralysis. If this was a survey that was used by non-otolaryngologists, maybe a score above a certain level would prompt them to refer the patient to us or consider additional workup. And finally, pediatric PROMs are definitely a less well-defined area for outcomes assessment. It has its own unique challenges. newborns to like age 3 and even older patients who maybe have speech or developmental delay, parents will fill out proxy assessments, and so it's really up to the clinician to determine how much of that is caregiver burden and how much actually reflects the child's experience. Nonetheless, there is good evidence for the use of the PROMS Pediatric Sleep Disturbance Item Bank and the Sinus and Nasal Quality of Life Questionnaire in those clinical contexts. But there's definitely still a recognized need to better define the role of patient-reported outcome measures in pediatric care and develop more robust and validated instruments tailored specifically to children. So the patient-reported outcome measures are gaining widespread use in clinical practice. They are still far from standardized and ubiquitous. There could be many reasons for this. I think first and foremost, the process of constructing, developing, and psychometrically validating these instruments is intensive. It's very much a non-linear process that involves patient interviews, content review by experts, pilot testing, and multiple iterations of that. Some opponents to PROM use cite a lack of rigorous validation for many of the PROMs in otolaryngology, even some of the more commonly used ones. In the systematic review we saw earlier, there were many deficits noted in the process of item generation and item reduction. Sometimes too many different subsites of disease were grouped together and led to development of a tool that was too broad, not sensitive enough to really detect clinically meaningful changes. And it's really important for these tools to be scientifically validated because they're going to be increasingly used as provider performance measures and to assess the quality of our care. Part of the problem is there seems to be a lack of patient involvement in developing a lot of these tools. This figure is kind of hard to see, but across the top are different properties of patient-reported outcome measures, and under content validity is, are there patient-derived items, or were patients involved in the development of the items in the tool? And you can kind of see a shocking lack of patient involvement in the majority of the instruments, whereas the column to the right or your left, that's whether or not content experts were interviewed, and they were involved in development of almost all the instruments, but you would argue that I think patients are equally, if not more important, to involved in developing these instruments. And then, unfortunately, many instruments lack a clinically significant correlate. Only 30% of the top 100 PROMs in OHNS have an MCID, or that minimal clinically important difference. And so you can imagine kind of the lack of motivation to use an instrument that can't be meaningfully correlated with patient changes and informed clinical counseling. So even with well-validated, great tools, there are still many barriers to use in practice. First and foremost, these questionnaires can be very extensive, multiple pages, laborious for the patient to fill out, and equally so for the provider to review. We have 10 to 15 minutes per patient visit. On the one hand, like a quick glance might clue in on severity of symptom or a specific area of concern, but when we consider to what extent individual scores are factored into decision making, I think it's quite limited. Part of that, I think, is related to the lack of a mechanism to integrate these scores into the electronic health record. In most cases, we're just manually inputting these scores, and it's usually just a total score, which on its own may very well be useless. That really ties into the logistical challenges, which I think is one of the biggest barriers to adopting PROMs in practice. Making sure the right forms are handed to the right patients. It seems straightforward, but in a busy practice can be the point where the process breaks down. And then inputting the information into Epic, whether it's manually or just scanning the whole form in, I think that it's leading to us not referencing these PROMs in most situations or just glancing at composite scores, which again can be limited in their efficacy. In most cases, I think that the information is just lost over time, and so I think that clinical integration is truly limited by whether or not it's integrated into the health record. And now that we're entering an era of outcomes-based reimbursement, PROMs are going to become a standard feature, I think, placing everyone at risk for survey fatigue and burnout. When we see a questionnaire like this, is it a patient that's fed up or asymptomatic? One way of potentially mitigating that is having instruments that are appropriately validated and actually correlate with clinical improvement, because you can ask patients all the questions you want, but if it's not been shown to be scientifically rigorous and actually correlate with improvement in outcomes, it's just another point of subjective data that's not going to be useful for actual practice. So how can we take PROMs to the next level and improve their implementation? I think the first step is digitization of the entire process. Within otolaryngology, Memorial Sloan Kettering Cancer Center has really been a leader in PROM integration, particularly into head and neck cancer care. This framework is based on what they've implemented at their institution, but I felt was helpful in kind of understanding next steps that we could take to improve the way that we integrate PROMs into our practice. The first, but likely most intensive step involves creating an electronic, user-friendly, and secure platform that enables PROM delivery to the patient and also collects that patient-generated data. That application then needs to be integrated with the electronic health record, as well as the institutional informatics database for storage and on which to produce advanced analytics. Physicians and specialists should then designate disease-specific PROMs to each disease and link that with an ICD-10 code so that when a patient is diagnosed with something and the ICD-10 code is linked with their chart, it triggers automated delivery of that PROM to them at that time. And then let's say they undergo surgery, a CPT code or a procedure code is input into their chart, and that triggers delivery of these surveys to them at post-treatment visits. MSK Engage, which is what they call their platform, has also implemented various components to try and mitigate survey fatigue, and one of those is a lockout period, so they can't deliver a survey for like X amount of days. I think it's 30 or 60 days after a patient has received one, so that they could theoretically have multiple visits without having to fill out the same survey multiple times, because likely the symptoms haven't changed that much. And then they've also incorporated computer logic guided triggers. So let's say they ask the patient, do you have any swallowing issues? They say no, then the computer can kind of automatically fill out 0 or whatever corresponds to asymptomatic on that survey and save the patient from having to do so. And then ideally you're collecting all this data, and the platform itself can generate advanced visual reports for the patient. Like this one is, again, from the MSK Engage platform for an oropharyngeal cancer patient. You can easily see, there have been studies that show that line graphs are some of the most effective in demonstrating progress in clinical settings, and you can see they've not had any problems with their facial appearance, but xerostomia has maybe become more of a problem. Swallowing function has been stagnant and fairly suboptimal, and so easy to incorporate into clinical counseling. Beyond trending data in an accessible user interface, these kinds of platforms can generate normative data, including responses across all patients with a specific condition by domain over time. And this data repository can be used as a benchmark for comparing an individual's performance to the general population, which of course can be used to enhance feedback for the clinician to assess each patient's progress, but also provide some insight on disease-specific patterns. So you can toggle over these individual domains and see like a scatter plot of patient scores for salivation, for example, at 1 month or 5 months post-treatment, and compare that individual score to the general population. And then on top of that, electronic platforms can allow you to kind of track what are the logistical hurdles that we're running into. You can see completion rate of surveys by individual physician, by modality of what kind of device patients are completing the survey on, and if there is a difference in completion rate for different surveys. The OHNS has actually developed a platform kind of like this. It is de-identified, so it's not incorporated into an electronic health record, but I think it's pronounced Regent. It's an ENT registry. It's primarily meant to mine data for research and quality improvement purposes, but It serves a similar function of allowing a physician, once you've signed up, to electronically deliver a PROM survey to a patient. Let's say a snot form to a patient who you're going to do surgery on, both pre and post treatment, and then it de-identifies the data that they put into the survey into a collective database that clinicians have access to. Again, it's not integrated into the health record, but it could be a highly impactful tool for assessing how our surgical interventions are improving or impacting patients' quality of life and health outcomes. And finally, I think the rise of machine learning models and technology can further catalyze PROM integration into healthcare. So PROs can be embedded as one of several inputs into an AI model that's trained to predict an outcome, such as a post-op PROM score or the likelihood of achieving the MCID at so-and-so time point after treatment. Valuable PROM data can also be integral to constructing personalized treatment plans. On the other side, AI is also being increasingly used in various capacities to augment medical decision-making and in the actual provision of healthcare. And so maybe PROMs can be the measure by which these novel AI-augmented healthcare systems are actually graded in terms of their efficacy compared to standard care mechanisms. So in conclusion, there are many psychometrically validated PROMs in every subspecialty of otolaryngology. The quality of instrument validation is really critical to utilization in practice, but nonetheless, these instruments have tremendous potential to really optimize health-related quality of life, enhance patient-provider communication, inspire novel endpoints of treatment for study and for research, and are becoming increasingly integral to assessing provider and institutional performance. A lot of future work is needed to standardize digitization, implement user-friendly platforms into clinical workflow and decision-making, and integrate PROMs into predictive models for screening, diagnosis, treatment response, and assessing disease-specific quality of life. Unrelated to the topic of presentation, but since I have the stage, I just wanted to take the opportunity to thank a lot of the mentors that I've had for various research projects and in other capacities over the last 5 years, and for your support in my learning and constant journey. Thank you.